All right, we're back. This is Senate Health and Welfare. We're moving on to H 545, a bill that has just come to us regarding issuing immunization recommendations, and we have the recorder of the bill from the House. So introduce yourself for the record and then a brief overview of the bill.
Thank you very much. For the record, my name is Son Eustace. I'm the representative from Wyndham One, which serves Guilford and Vernon. So, H 545 bill of hands is a bill for the particular moment in which we find ourselves. The passage of H 545 will enable Vermont to keep life-saving immunizations available to its own citizens. The bill under consideration was first crafted and requested by the Commissioner of Health in anticipation of potential changes in federal immunization policy at the Centers for Disease Control and Prevention. The Commissioner's request was well-timed indeed. Just the day before the bill was introduced to the House, the CDC introduced a series of significant policy changes for immunizations. Overnight, and against the recommendations of such organizations as the American Academy of Pediatrics and the American Academy of Family Physicians, 35% of the CDC's previously recommended immunizations were removed from the schedule. This bill contains no mandates or directives for immunization for individuals or families. What this bill does do instead is to enable the state of Vermont to issue its own evidence-based recommended immunization schedule. The federal schedule will still be available. It authorizes the Department of Health to continue purchasing those recommended immunizations at the lowest cost available, and it provides for continued insurance coverage at no cost to those seeking immunizations. So the bill works on three levels. The first bit is just some minor technical changes that need to be made. The second is that it proposes authority for issuing recommended immunizations in Vermont. And the third level is that it offers a sunset in 6 years and returning the authority to current law and to the Centers for Disease Control and Prevention. So the main technical change, language change that was made in the bill was in the statute. You often find the word vaccine or vaccination. That's been changed to recommended immunization throughout. And then there were just a couple of minor changes that were made. But turning to the guts of the bill, Section 1, existing law authorizes the Commissioner to operate a program with the goals.
So I'm going to recommend that you give us the high level because we're going to walk through with.
Okay. All right.
Yeah,
okay.
let's do that.
All right. Okay.
Your background is helpful.
All right.
Yeah.
Okay. Good. So the Section 1 just well, most of the bill exists. I should say that it's current law.
Yeah.
The new law is that's being suggested in this bill, Section 2. And that's the point at which the Commissioner of Health would be authorized to create the schedule of immunizations and work with Vermont Immunization Advisory Council to develop that schedule. Sections 3 through 7 of the bill simply take existing law, put it here so that it's all in one place. And then the final sections 8 through 13 are the sunset language. For 6 years out. And I have the a long list of folks that testified for us.
That's good. We can look that up.
Yeah, okay. And the bill was recommended to the House on a vote of 10-1-0 in our committee. It was also reviewed by 3 other committees. 2 of which were unanimous, the Appropriations and Ways and Means, and then Judiciary reviewed it as well, 9-1-0.
And the vote on the floor
Was one, I forget the exact number, there were 9 negative votes.
Okay, so it was a voice, it was a roll call.
It was a roll call.
Oh,
It was a roll call.
9.
9 negative.
It sounds like it was supported very well.
Yeah, it was also.
Thank you.
Any questions?
Oh, it's good to have you in committee. First time.
All right,
So, and this came out of which committee?
Human Services.
Human Services. Yeah, that'd be.
All right.
Okay,
Thank you very much.
so, and the vote was like 127,
So 127 to 9.
Yeah.
That was $5 per. And there were, I think, 12 absent that day.
wow. Katie. I see it's a strike off.
Always.
You do have a phone copy.
Good morning, Katie with the Office of Legislative Council. I will share my screen and pull this up for you. As pass version. So before we jump in, let me just sort of step back and tell you a little bit about what's in the bill. I think it looks daunting at 24 pages. What you should know is that there is a sunset on the provisions that are put in place by the House. Meaning that after 6 years, most of the changes go back to as they are in current law, not everything, and I'll point out where there are some differences. But in terms of drafting, what that meant is we had to duplicate the statutes that are being amended twice to show the change that would take place on passage and then the change that would take place after 2 years. So it almost doubles the size of the bill having that sunset in there. So I will go through that with you. The primary thing that this bill does is right now in current Vermont law, the recommended immunization schedule for adults and children is linked throughout the VSA with the CDC's recommendations, and that governs language about which immunizations can be purchased, the authorization for pharmacists and pharmacy techs to administer it, how reimbursement works for health insurance. So instead, this bill sort of decouples that link with the CDC for recommended immunizations, instead gives the Vermont Department of Health the authority to develop recommended immunizations. And it would be sort of a 6-year replacement of having the Commissioner of Health's recommended immunizations in place of that coupling with the CDC. I'll pause there and we'll jump into the language. So in section 1, we have a definition that's currently immunizations and it's being changed to recommended immunizations. This is probably one of the most significant changes in the bill is the use of recommended immunization. It means something very specific here. In current law, you'll see on lines 14 and 15, these are guidelines that are established by the Advisory Committee on Immunization Practices to the Centers for Disease Control and Prevention. So right now, the definition of immunization is linked to the CDC recommendations. You'll see that language is struck through, and instead we have language that a recommended immunization is established by the commissioner pursuant to a process that's set up in this bill. So when we see the term recommended immunization, that doesn't mean any immunization. It means an immunization that's recommended by the commissioner. Another change in this definition, under current law, an immunization means a vaccine or the application of a vaccine. What this language says means a vaccine or other immunizing agent that provides protection under a particular disease or pathogen. I know you have lots of healthcare providers here to talk to, and you can explain this better than I can. But the explanation in Human Services was that immunizations are not always administered by vaccine injection. So this is meant to be a little bit broader and capture that. So that is the definition of recommended immunizations. In this section 1 that we're looking at, most of this is existing law that establishes the immunization program that's administered by the Department of Health. This language governs how and which immunizations are purchased, who they're purchased from, It governs, how, a calculation is made, to know what insurance companies have to remit to the health department to fund the program based on, the number of people served by the program receiving immunizations under Vermont's program. So to take a look at that, in subsection C1, so the department is to administer an immunization program. This is existing law, with the goals of ensuring universal access to recommended immunizations at no charge to the individual and reducing the cost at which the state may purchase recommended immunizations. The department shall purchase, provide for the distribution of, and monitor the use of recommended immunizations as provided for in the subsection. The cost, yep,
I was just gonna suggest that. we-
higher level.
Yes.
Sure.
That, but we won't get to everybody in the room if we keep doing.
Okay,
this. So,
okay.
I mean, a high,
Higher level. We can go
10,000.
back in more detail later.
yes, we definitely.
Sure, I can do that.
will. Okay.
So we've already covered, I would like to cover C. That the department is to determine which recommended immunization shall be purchased under the program. Human Services added language that the immunization program shall purchase recommended immunizations consistent with the goals of the program. So that was a change from Human Services. I will skip over this language about how the funding for the program works. What is noteworthy is this subsection G. This is an existing immunization funding advisory committee. This committee looks at the annual per member per month cost for recommended immunizations. They would have the same task, except, you know, for recommended immunizations instead of linked to the CDC. There are some changes that are technical to the membership of the board, not substantively the members. But I flagged that because after 6 years, when we revert to the current language, these changes to the way this group is structured would be maintained. Okay, I'll skip over this. Subsection 2 is all new language. This is where we get the parameters for what the new authorization for the commissioner looks like. So the commissioner shall periodically issue recommendations regarding which immunizations children and adults are recommended to receive, at what age each immunization is recommended to be given, the number of immunization doses that are recommended to be administered, the recommended amount between time of doses and immunization, and any other recommendations regarding immunizations necessary to promote the maintenance of public health and disease prevention in the state. Subsection B is important. This is telling the commissioner what the commissioner needs to consider prior to issuing recommendations. So first, the commissioner has to consult with the Vermont Immunization Advisory Council. This is an existing council and existing law. This bill does make some changes to the membership, and we'll look at that. Second, the commissioner has to consider recommendations made by various professional groups, one of which is the CDC, but also recommendations by the American Academy of Pediatrics, Family Physicians, American College of Obstetricians and Gynecologists, American College of Physicians, any other organization the commissioner may deem necessary. So that is an important subsection. Subsection C has language about immunity from liability. If a healthcare professional who prescribes, dispenses, or administers an immunization in accordance with the recommendations from the commissioner, they would be immune from civil and administrative liability for an immunization caused adverse event, unless that professional person who's doing the prescribing, dispensing, or administering, if their action constituted gross negligence, recklessness, or intentional misconduct. Subsection D gives the commissioner the authority to issue a standing order for recommended immunizations. Subsection E, this is language that was added by Human Services. It wasn't part of the original proposal. That the department is to prominently display information pertaining to recommended immunizations on its website, including how to access them. And in 2, any documents that are produced by the department about recommended immunization shall include a disclosure if the recommended immunizations differ from the recommendations of Vermont's Immunization Advisory Council. So, we know that the commissioner has to consult with this group. If the commissioner ultimately has a different recommendation than that group, then that has to be disclosed on Department of Health documentation about the recommended immunization schedule. Section 3 brings us back to existing law. I mentioned that the Vermont Immunization Advisory Council was existing law. The membership does change in this draft. Let's see, we have added a board of nursing, board of pharmacy rep. There had been a representative of public schools and independent schools. Independent schools was removed. There's the addition of the Department of Health's immunization program manager. The addition of 2 individuals who are professors, researchers, or physicians, or any combination of these individuals with expertise in infectious disease and human immunization. The addition of a family or internal medicine physician. Also the addition of a practicing APRN, a practicing pharmacist, and the other existing law, any other person deemed necessary by the commissioner. So the duties of this group is changing because now, in addition to their other duties, they're also providing recommendations to the commissioner on establishing a Vermont recommended schedule. So you'll see in subdivision C1B that we're adding this clause on my line 6 and 7. I don't know how it's printed in your handout. That including advice regarding recommended immunizations as defined in 1130. That was the first definition we looked at. So we're adding that to their scope of this group's responsibility. Also happening in the 6-year period is the addition of this language that the Secretary of Education or designee and the representative of public schools shall not vote on advice regarding recommended immunizations. So those 2 individuals are part of this group now. But with regard to creating the recommended schedule, those 2 folks would not be voting. They wouldn't be contributing to that vote. We have some changes to the membership of the meeting. We can talk about that later. I'll move on. The next 2 sections have to do with health insurance. Right now, there's no cost to the consumer for receiving immunization as recommended by the CDC. You'll see that the language in these 2 sections are linked directly to the CDC recommendations. So this strikes through that reference and refers back to the definition of recommended immunization created in this bill, which again means that the Commissioner of Health created that recommendation. So that's sections 4 and 5. Sections 6 and 7 deal with pharmacists and pharmacy techs. Again, right now, their authority to, for pharmacists to prescribe or to administer is tied to the CDC authorization. So in Roman numeral 7, you'll see that instead of having the language that links to the CDC recommendations, we're replacing that with the definition of the Commissioner of Health making those recommendations. Same thing in 8. 7 applies to pharmacy techs, and we have similar changes happening in this section. I know with regard to the pharmacy techs, OPR has reached out to me and they want to tighten up that language. So I am in the process of working with them on bringing something back to.
That's good. We'll probably hear from them today.
Okay. So when we get to section 8, Human Services worked really hard on these reader assistant headers because the bill is sort of complicated with different effective dates. But you'll see section 8 becomes effective on July 1/31. So we've reached the halfway point in the bill where we start going back to where the language was at the current point in time. So I'm not going to go through all this. I think we'll have time when people aren't in the room. But needless to say, the language generally goes back to the way it is now, with some exceptions that I can point out to you. The language that, the new language that creates a new section that has the parameters for how the Commissioner of Health has to make its, the determinations for recommended immunizations. That section completely sunsets after 6 years, and everything else kind of reverts to where it is now, for the most part, with exceptions. And then we have a complicated effective date section, which makes sense because we have a lot happening, in terms of half of the bill taking effect on passage and half of the bill taking effect to revert back to the current law in 2031. That was fast, but
No, that was good. That was good. And I know that some of us are familiar with this, and as we go forward, we'll hear from folks who are deeply embedded in the process, boots on the ground. So thank you for that. Questions from Kate? I think it's pretty clear. Yeah. All right, so let's move on. I'm gonna skip over, Stephanie Winters, because she's in the building more frequently than others. And move on to Tracy Tyson, who's here, soon. Thank you for being here, Dr. Tyson.
Good morning.
And, we have, our time is always limited. So thanks for being here. Go ahead.
Thank you for having me. My name is Dr. Tracy Tyson. I'm a board certified general pediatrician in private practice in St. Albans, as well as the president-elect of the Vermont American Academy of Pediatrics. I'm so glad to be here today. This is my third time speaking on this bill. I can't impress upon everyone how important this bill is. Like, this is important enough that I've canceled 3 days of clinic to make sure that we can speak about this, and it's extremely important. So what we are seeing right now is some unprecedented times when it comes to the increase in preventable diseases. So we're having some of the largest amounts of pediatric death in over 2 decades from the flu, which is coming along with the timing of the CDC changing the recommendations to the flu vaccine to not being routine for everyone. So we saw even more decrease in flu vaccination rates this year. We're having the largest measles outbreak in 30 years, as well as whooping cough and all of these preventable diseases, which are directly related to the public's mistrust of vaccinations. The American Academy of Pediatrics has been pretty clear on the recommendations, and we now have the 12 major medical societies in the United States that have all backed the American Academy of Pediatrics vaccination schedule in opposition of the CDC's non-science-based recommendations. What are we actually seeing and what are we hearing from families? They are very confused. They don't understand what it means, and they're making decisions without true informed consent. So we're hearing from our hospitals that there is increasing numbers of families declining the hepatitis B vaccination at birth, not because they have concerns, but because they think it's not recommended anymore. In clinic, we have families in record numbers that are decreasing the want for vaccinations, but we also have a lot of families that are very concerned that they're not going to have access to vaccines, that they are not going to have them be able to be paid for, and they are asking questions like, am I going to have to go to Canada to get my child's vaccinations? What are you going to do to try to make sure that we have access? We also have providers who are fearful for how are they going to continue to provide care if they are not feeling confident. Which vaccine schedule are they legally allowed to do? We saw when the COVID vaccine rates, when the recommendation changed, we weren't able to get it. And there were, pharmacies that might not feel comfortable giving it. So when these lapses in care happens, we're going to start to see significant preventable illness. Part of this bill, we also have, a lot of negative attitudes towards physicians related to vaccinations. And so we also have concerns. The state medical board is also, having to get involved when doctors like myself are giving evidence-based information regarding vaccinations. If that is different than the CDC, there have been reports where families have even made report to the Board of Medicine that we are not following guidelines. So This is extremely important, and I'll be honest, I'm worried how I'm going to do my job if we don't have something like this. And I thank you so much for taking a look at this bill and everything that's been done up to this point.
Oh, thank you very much. That was concise and well, well done. 5 minutes, did it? I did not realize, Dr. Hildebrand, that you have a hard stop at 11 o'clock.
I do.
So, why don't we just quickly bring you up, and Dr. Tyson, if you don't mind sending your testimony, and that would be great.
Thank you for having me. Rick Hildebrand, Commissioner of Health for the record. And I will build upon what Dr. Tyson has said.
You have a team here, so.
I do.
Okay, that's
I have Lauren Lehman, my general counsel, and I've got Meredith Plumpton and my immunization subject matter expert, as well as Jessica. There's been a lot of confusion that we've seen across the state, across the country, related to falsehoods and tweets that have been spread. There's confusion that we have had at the health department because we are not clear where the changes in these recommendations have come from. There's years of rigorous scientific research that have demonstrated the value and the schedule that we use to immunize our children. And those were changed in an abrupt manner that has caused a lot of disruption. We are committed to preserving access to vaccines to our Vermonters, and that is something we've heard as a need from pediatricians, we've heard from Vermonters. We need to make some changes to ensure we preserve that access. There's a number of things that are in this bill. I will try to hit on some of the highlights and some of the reasons we're doing this. Transparency is critical here. We want to make sure that we are very clear as to where these recommendations are coming from and why we are making them. Which is why we are trying to assemble a panel of experts and relied upon sources such as the AAP and the AFP, which have guided the ACIP for every single iteration of the recommendations, except for this one where they did not take them into testimony when they were developing their guidance. AAP was also foundational in creating ACIP, which is why it's very confusing why they was diverged from that practice after so many years. The current federal system provides 3 elements that we're trying to protect here in Vermont. Science-based reviews and recommendations of the vaccine schedule, purchase of vaccines at a low cost, and protection for healthcare providers. There is all 3 of these are currently in place at the federal level. We are trying to maintain them in spite of the changes that have happened recently. Okay, these are not new things that we're doing. We're just trying to preserve them. So there's a number of bullets here that have been touched on already, and I will reinforce. We will have the flexibility to follow the vaccine schedules from ACIP and CDC, in addition to the professional medical organizations such as AAP, AFP, and ACOG. Those 3 professional organizations routinely publish vaccine schedules and have for decades, and it's something that we've relied on as providers, and frankly, ACIP has relied on for many years. So we'd like to use that in addition to the expert vaccine. The immunization program will be able to purchase the vaccines at the lowest available cost. So the program that we use, Meredith can go into much more detail than I can, but we acquire vaccines from the CDC at a lower cost, use a group purchasing platform to provide the vaccines to us and distribute it to our practices here in Vermont. If we lose the ability to do that, which we are worried may happen, we need to have an alternative. That needs legislative changes to allow us to do that. We want to have the same cost of Vermonters and the same distribution ability. If CDC goes away as a source, we want another one. That has not changed to date. Okay, to be clear, the changes that have happened so far have not impaired our ability to acquire vaccines. I'm very fearful though that will be coming. Insurers currently provide coverage for vaccines in Vermont. We are a universal vaccine state. It is covered for by insurance companies. Okay, this is not state dollars we're asking for to cover this. The insurers will continue to provide those vaccines as recommended by me and by science-based recommendations to the Vermont. Pharmacies and pharmacy techs have been allowed to administer these vaccines. Access is important. the number one thing I hear from patients when I'm seeing them in the hospital as to why they didn't get a vaccine is, I just haven't had time. It's been inconvenient. I couldn't get into my primary care office. Access is important. If we make access available, people will do what they know is right or what they feel is right. It's oftentimes an access problem. So we want to preserve that access with the pharmacists. We want to have the ability to have a standing order so that we can administer the recommended vaccines as recommended. And then there's a liability piece. Again, there is a program, a federal program that has been in place for many years around vaccines to help compensate individuals who are harmed by any ill effects of vaccines. There are incredibly rare cases where people are harmed and they're covered by this program. This extends the protection to providers using the recommended vaccine schedule. Anybody who has an injury related to a vaccine is eligible for this program, regardless of what schedule we're following. Okay. There's immunity currently in place. If you follow the recommended vaccine schedule by ACIP, that you will not be under personal and again, Lauren can answer all these questions. I'm not a legal scholar. She can answer all these much better than I can. This just continues the protections that have been in place for the vaccine schedule. Okay. And again, I can't say this loudly enough. This is not a vaccine mandate. This does not mandate anything from anyone. Okay. This is just preserving the access to vaccines for Vermonters at the lowest possible cost, allows for access in pharmacies, and provides the liability protection for the providers. So that is very high level, very quick, but I did want to leave some time for questions because oftentimes there are questions and I do have if there are things that people have off the bat before we go to Meredith or Lauren.
I don't have a question, I have a comment.
Yes.
Thank you for doing the work. Yes. It's an important medical process for the state. Yeah, really appreciate it. And I know that once you mention the word vaccine and vaccination and immunization, that it raises all kinds of issues with people, that we need to continue what we've been doing in the state to maintain the health of the state. We're number 3 in the country, and it's partially due to this kind of work. Questions? That was short and sweet.
Try to be short and sweet.
Some people may not think it was sweet, but I don't.
And if there are questions that arise as a result of either the conversation with Meredith or Lauren, please, I'm happy.
I know there are a lot more slides than what we have looked at.
Correct. Those would be with Meredith and with.
So we're going to continue that. And do you two want to come up together, or is it better to be separate?
Probably separate, but we'll both go.
We like quick. I know, we don't have a lot of time, so if you be concise, your testimony is extremely helpful. Thank you for being here. Sure. We haven't introduced ourselves and you're new to the committee, so I'm gonna have us do that right now.
Sure, I'm Meredith Plumpton. I'm
Not you.
Us.
That's what you feel.
Face is so red.
The end. No, you're fine.
John Morley from Orleans. John Benson from Orange.
Jenny Lyons, Chittenden Southeast.
Martina Rupp, you are Chittenden Central. And Cummings, Washington.
Thank you. Now, for the record.
I'm Meredith Plumpton. I'm the immunization program manager with the Vermont Department of Health.
Thank you. So the way ahead.
So Dr. Hildebrandt talked a little bit about the way that our program works. I just want to dive into a little bit more detail so that you have a good understanding of the need for changes. Currently, we utilize the CDC contract to purchase vaccines for all children and adults age 19 through 64. And I'll explain that in a minute. We use a combination of federal funds and ensure funds in order to purchase those vaccines. We distribute them to all primary care providers' offices in Vermont. And we currently align with, oh, in the past, we have aligned with ACIP recommendations. So a little bit about the universal program. I'm a visual learner. I like little graphics. So you can see that the Vaccines for Children program is a federal program that serves about 50% of kids in Vermont. And those vaccines are for Medicaid eligible, uninsured, or children that are on Medicaid. And there's a couple of other smaller buckets. And then we use insurer funding for about the other half of children. We get a very small bucket of money from the federal government for uninsured adults. It's about 10% of the vaccines that we purchase for adults, and then the private insurers pay for the other 90%. We do this through the Vermont Vaccine Purchasing Program, which that funding that Katie was talking about, that funding committee is comprised of people who look at what the per member per month cost is to those insurance companies that they pay to the health department so that we can purchase those vaccines. So it's a little bit confusing.
No,
but,
that's good.
we want to be able to continue to offer all recommended vaccines. And like Dr. Hildebrand said, if those vaccines are restricted through the CDC contract or no longer offered through the CDC contract, we want to be able to go to another vendor, still the same vaccines themselves, but go to another vendor to have those vaccines shipped to our providers so that they can continue to use them. I said that our program is for birth through age 64. It's because Medicare doesn't currently pay into our program, so we don't offer vaccines for Vermonters 65 and older right now. We are working on a solution to that, and I hope to see you guys in the future about that. The next slide just talks about how we communicate with providers. The providers are our customers, and we communicate with them regularly with information, with newsletters, with webinars, with all sorts of information. And then I have 3 examples. I'm just going to choose one in the interest of time. I think I'm going to go to the Hep B example. So ACIP made a recommendation to remove the universal hepatitis B birth dose. That recommendation, the universal hepatitis B birth dose, that recommendation has been in place since 1991, and we've actually seen a reduction of 99% of hepatitis B cases in children and adolescents since that universal recommendation was put in place. So we would still like to recommend that universally. All of the national medical organizations are still recommending it universally. My fear is that they take a look at our hepatitis B cases, which are below a dozen a year in Vermont, and say you can only have vaccines for 100 kids, and we have over 5,000 births a year. So this is where that new flexibility with the bill language would come in, and we would still be able to purchase hepatitis B vaccine for all infants, parents, on their children vaccine. There is a slide about the new changes to the vaccine schedule. I'm not going to go into details with it, but just wanted you to have that information. And again, I will reiterate what Dr. Hildebrand says, that this bill has nothing to do with mandates. We're not looking at changing childcare and school requirements. This is just to maintain the access of your kids. Any questions?
Good. Questions? We know where to find it. You do? Lauren, we need the legal.
Yes.
And I forgot, you are at CDH. I
Yeah,
put
I
you
was
at
not-
OPR earlier.
I was not in here with the other just was
You were still.
new role for me. Thank you. I'm Lauren Lehman. I'm general counsel for the Department of Health. And I'm not gonna, I think I'll reiterate what my colleagues said. It's about access. This is about ensuring continued access and emulating a system that was on the federal level that is changing overnight in ways that are unpredictable and not always scientifically based or evidence-based that we can tell. So when these impacts started to affect us, when we anticipated them, we engaged in collaboration with a number of other cross-agency department, as well as with other stakeholders in the community to talk about what things needed to change. And that's what H554 is what you see before it. And we, identified not only problems, but solutions for those changes. We wanted a clear, transparent process for issuing those immunization recommendations that considered the science, considered other recommendations. We wanted to allow for flexibility to purchase, as Meredith just said. We wanted to ensure private insurers continue to cover, and they've been supported so far. And without cost to the individual, no copay, no coinsurance, no deductible. And we also wanted to address some of the potential barriers faced by that might deter healthcare providers from offering vaccines and immunizations more globally. So I'm really here to talk to you about those protections, in particular that liability protection you see in the bill. I think that was a concern over on the House side, and I wanted to walk through that a little bit with folks. So right now on the federal level, if you have an injury that is from a vaccine, very rare, as Dr. Hildebrand said, but if even one case, could result in a tort case for a provider that's very lengthy, very costly. And in the 1980s, this was deterring healthcare providers and manufacturers from both manufacturing and providing the medications or the immunizations. So the federal government created the Vaccine Injury Compensation Program, and it prohibits. Now, if you have an injury over $1,000, you cannot go to the civil courts. Civil courts can't award any damages above $1,000. You have to petition the Vaccine Injury Compensation Program for any compensation. And the injury compensation to the family is then paid out through a fund that is paid into by excise taxes. So it's just for covered vaccines. Those vaccines are put in there by the feds or by the Congress by adding an excise tax to the vaccine, fills the fund. If there's an injury, it's paid out of the fund, insulates the manufacturers and the providers from liability. Families get compensated, and things can move forward without that tort case law. We can't fill that on the state level. Unfortunately, but what we can do is to continue to ensure access. We protect providers who are acting solely in accordance with the recommendations from the commission. So this provision in the bill is much more limited than that federal protection. Our concern is that there will be changes to the Vaccine Injury Compensation Program. Vaccines will be removed. It's Congress to add a vaccine. The Secretary of Health and Human Services can remove one by rule. So we're concerned that vaccines will be removed, injuries will be no longer covered. And so we would like to be able to provide some liability protection on the state level so that if a provider is acting 100% in accordance with the recommendations, they will not be liable for neglect of those activities.
So right now, see, a year ago, there was a CCD set of guidelines.
Yeah.
If somebody felt their child themselves were negatively affected by getting this, and you said, yeah, they got a shot from their doctor. They similar to workers' comp, rather than go and tie everybody up, and you would go to this board and there is a compensation mechanism. What this bill would do is say, rather than CDC recommended vaccines. The provider is protected if they are doing the state recommended vaccines under all the proper guidelines. So it's not changing anything. It's not extending protection to anyone that didn't used to have protection.
That is absolutely correct, and in fact, it provides less protection than the federal level, because the federal level also provides liability protection for manufacturers as well as providers. So drug companies, ours would not do that. And this also, there's still a lot of recourse people would have in the court system. So for example, if there was an injury caused not by the administration of a vaccine in accordance with the schedule and the age and all that stuff, if there was enough for failure to provide informed consent, for failure to, put it in the wrong arm, it's not, you didn't check to do what your process, what you should have done, there's still liability protection. Or nothing.
If it's done according to Hoyle, it's, but it doesn't extend it to manufacturers. The Fed, because I've heard concern about COVID and extending immunity. Whatever immunity is there is presently in federal law. If the feds remove that immunization, we are not restoring it to manufacturers, merely to the administrators who are legally allowed to administer, and they have to do it according to legally required medically good practice statements.
Scientifically sound, evidence-based, transparent decision between the provider, recommended by a provider, doing in accordance with the state recommendations, doing everything that they're supposed to do in accordance with science. And, 1 in a million, a person will have a reaction. And that's nobody's, that's how they.
That's probably well to have in mind for my job.
Yeah, from your
Senator Cummings brings up an interesting question. So at the CDC level, there's a fund, I think you said, for if somebody has a thing. CDC is no longer going to do that under certain types of immunizations. The state of Vermont's going to do it.
No, so thank you for clarifying. So right now, nothing's changed at the vaccine injury compensation program, but at the federal level, though we anticipate it might. And we would not provide that. This provision solely protects the provider from liability if they're following the state recommendations. So the person who's injured can still seek compensation for any other injury, for any other problem through the court system. Can pursue it against the manufacturer if they want, but it wouldn't be against that one provider who administered the vaccine following all the guidance from the state.
Gotcha. Thank you.
One other thing, and I'm open to, of course, open to other questions about liability, but I wanted to touch quickly on informed consent because that came up in the House Student Services. So under Vermont law, healthcare providers are required to provide informed consent for every procedure. If they don't, they're subject to medical malpractice liability. And there's a statute, it's 12 VSA 1909. And that walks through what is required in informed consent, which is that the provider tell the patient about all foreseeable risks of a procedure or treatment. And that's important because it defers to the provider to be the expert in their field and make sure they disclose to their patients that here's all the things we know from the science, from the studies, et cetera, that proven established foreseeable risk of this medication or procedure. And we've decided many times not to make specific informed consent standards for different types of procedures that are much riskier than a vaccine. And I think and I know that the department for access purposes, et cetera, would like to keep that standard as is and not a different informed consent standard for vaccines. There's also.
What was the 12 VSA what?
1909.
Oh, 1909.
It's 1909. And there's also federal requirements right now that we disclose vaccine information, statements, et cetera.
Going back to my last question, informed consent. Right now, if, and I assume continually, as long as our list is complies with the federal list, if there's a negative reaction or the families have access to this federal recompense program. If, when this goes into effect, there is a negative reaction and the CDC has removed FC from the list, then would the family be told that they didn't have, they can't sue the doctor and there's no recompense program? They could sue the manufacturer, which is a much deeper pocket. Because if the provider did something wrong, like use dirty needles, the provider then is not protected. The provider would be protected. So I guess the alternative would be, rather than sue your local provider, it would be to sue the manufacturer, because the problem would be with the vaccine, as long as the provider said, oh, and if in a rare case your child would develop, no, that's syndrome that you asked. Right. Yeah, I mean, so as long as that's disclosed and it's done correctly, so, but you would have to sue the manufacturer, right? All right. I need to interrupt because I want to make sure that no one in the room is reporting the activities. They are available on YouTube. So, okay, keep going.
So I did want to say that, yes, so you're correct. So, if, for example, the doctor would disclose there's a small risk of Guillain-Barré syndrome, which is an autoimmune infection. And the parent or the child or the individual would say, I accept that risk. Just like you go and you get your anesthesia form read to you, or you didn't say, I accept that risk, you know, I would like this vaccine. So that's already in place. It's already something that needs to be done. If after the fact the child develops Guillain-Barré syndrome and it's not covered via CP, and that all these, and you know, the child was safe for grade age, it's right dosage, it's right schedule, and it was in accordance with this stage, then all the sanitation, there was no gross negligence, which is, you know, being reckless or careless, not following the procedure. If at that point that provider has done everything right, they're not going to be liable for the reaction. The manufacturer still can be, if they are neglectful or grossly negligent, if they do something like don't sanitize needles or something, then they could still be liable. That's all right.
That's it?
That's it.
Good. We got a question.
I understand what you just said, and I think it, of course, raises the hurdle in terms of actually getting in compensation, because now you're going to go up against the manufacturer. But set that aside. What I was curious about is, what about the state itself? We were adopting a different set of standards than the CDC. Does that expose the state as all to any potential lawsuits or recourse as things go forward?
It's an interesting question. We have very strong state sovereignty law and case law, so in most cases we would be protected, but it's an interesting question. And you know, that's why we can do things with the standard of care, scientifically based, evidence based, so we would have that backing for our recommendations should any lawsuit arise.
Good question. Are there questions? Are there questions? I'm going to suggest that we Dr. Tyson, were you coming in to say something? Okay. Oh, I'm gonna suggest that we postpone, Stephanie Winters for another day. Is that acceptable to you? Well, we'll take some more testimony. I know the folks who have asked to testify on this. And then we'll make sure that our questions are answered. I think it's been really helpful to have Department of Health and, Ian today, particularly on to leave. But thank you.
Thank you.
That's a wrap. We're gonna go offline.